It's my honor now to introduce Dr. Deborah Kuhls, who is a professor of surgery at University of Las Vegas School of Medicine. Dr. Kuhls is a well-known trauma surgeon with a national reputation and has had several prominent positions. She's very well known in surgical education, but also has made a very big name in injury prevention. I first met Dr. Kuhls when I was on the Committee of Trauma, and shortly after I joined, this woman cornered me in a cafeteria in a convention center in Chicago, started asking me questions about the course that I was offering, which was the disaster course, and how she was going to bring it to her institution. And before too long, myself and Dr. Coimbra were flying Southwest into Las Vegas on a couple occasions to deliver the disaster course to Las Vegas. That was well before the events of the 1st of October. She's also, on the injury prevention side, been very prominent in trying to figure out ways for providers, and particularly for surgeons, to take an active role in reducing the burden of gun violence in the United States, while still respecting the cultural norms and the Constitution that we have. And I think she's done a masterful job of that, and she'll talk about that as well. She's contributed some items to our syllabus that you can look at. We'll add a few more in the next coming days. But I hope you give a big hand, a big warm round of applause to Dr. Kuhls and her talk on Las Vegas mass shooting.
Okay, so anyway, I have a lot of material. I'll go through it pretty quickly. I'll make my slides available if there's a mechanism for you. We want to talk about how to maximize survival. Let me just make sure I know how to. Let's see. I don't have any disclosures. I would assume most of you have been to Las Vegas. You go there probably for entertainment reasons, as do many people. We have about 2 million people who live there, and it contributes very significantly to our economy. We're an isolated area, though. It's about 20 by 40 miles in kind of area, and it is very geographically isolated. We're 4 to 5 hours away from all the other metropolitan areas, including yours. So if something happens there, like all trauma, it's pretty local for quite a while. So we'd like to think that we have an organized trauma system, and I think the San Diego area trauma system is always a model as well. We like to think that we have a coordinated way of responding to injuries. We think we do it daily. We think we can adapt to large influxes of people. There are a lot of events that happen in Las Vegas. We practice our disaster response very frequently. And I would say for every major event, there is a plan for how to take care of the injured and ill. We have a total of 9 EMS services, 6 public and 3 private, 1 fixed wing and 1 rotor wing. None of our hospitals own these directly. So when we look at overall hospitals, we have 17 with the emergency departments, and we have 3 ACS verified trauma centers. I work at the level 1. We also have level 2 and level 3, and they played major roles. So this is kind of what the valley looks like. The yellow diamonds are where the trauma centers are, and you can see the level 1 and 2 are relatively close to one another. This is where the Las Vegas mass casualty shooting occurred. And so you can see that it is between actually the level 2 and the level 3 trauma centers. I need to go back let me see if I can figure out how to go back. If not, what I would say is all the other hospitals are there as well. I'm not sure I know how to go back. And I want to point out this little yellow arrow here because the McCarran Airport goes right up to the Strip, as most of you are aware, and some of their housing for fuel is in this area as well. The red area is where the mass casualty shooting happened, and it's 7 acres. There were 22,000 people present when it happened, and in 13 minutes, as most of you know, more than 1,100 rounds of military-grade ammunition were fired. And not all of it actually at these people, but most. So when we look at it, it sort of started a little after 10 and ended at 10:21. 4 minutes later, the first patient started arriving at Sunrise, and 3 minutes later at UMC, the level 1, which is where I work. And actually, I should probably put patients because they came in waves, not just one by one. So overall, as most of you know, 58 people, not including the shooter, lost their lives, and we treated over 600. Like a lot of other mass casualty events, about 80% self-directed to medical care, and more than half were visitors. I would assume that you have been taking care of some of our victims. Just a few pictures from the site. Many of you have seen these. They're really horrific, a lot of acts of heroism. And this last picture shows the dead, and this was a crime scene, and it remained a crime scene for a long time. And the families, didn't know if their loved ones were killed or not. So there was, I think there was a lot of distress in many of the people who attended there. This is kind of an interesting little graphic, and it has to do with cell phone activity. So these people around the perimeter, I think they didn't have tickets, and they were just kind of listening in. After the mass casualty shooting, they started to spread, and other people left the area as well. A few minutes later, this is what it looked like. So you can see that people really went, this would be in a direction that would be east of the event. West of the event, you don't see any activity because all those roads were closed very quickly. A few minutes later, it looks like this. So a few people tried to escape either to Henderson or to the airport, and then this is the airport here. In the airport area, this is where some of the fuel is stored, and we later learned that the shooter actually shot multiple shots at the fuel, trying to cause an explosion in addition to all the other harm he did. And that isn't terribly well publicized as well. I'm going to give you a little bit of experience at my level 1 trauma center, and a little bit on the overall trauma system. So this is where I work. It's a standalone facility, the only one of its type west of the Mississippi. So only trauma patients and burn patients actually come in here. We admit about 3,400 a year. We have a full-time emergency doctor and a full-time trauma surgeon in the team that work there every day. So this is again the site, and here's how you get to our trauma center, which is the freeway. And it was one of the roads that was closed very quickly. I don't think we know quite why it was closed. The FBI report is promised before the October 1 first anniversary. So where I work, we have a little over 500 beds, and we have a main emergency department and a separate trauma center. They're connected by hallways and so forth. But if you're going to get here, the quickest way is the freeway. Our main operating rooms are separate from operating rooms in our trauma center. So this is kind of an overview of our trauma center. We have 14 resuscitation beds. We have a CT scanner, angio suite. We have our own PACU, 3 ORs, and then wrapped around it is a 14-bed trauma ICU, which I am privileged to manage on the physician side. So what happened on that day? For myself, I'll just disclose I was the AM doctor. Our shift for accepting new patients ends at 7. After 10, we were still there because we were really busy during the day. And then all of a sudden, we literally got a no-notice mass casualty alert. So we stayed in-house as well as the 19 that had already arrived. So the first notification was at 10:15, so we decided to stay in place. And then literally a minute later, we heard 5 to 10 people were coming our way. And then they turned around, they said, no, we heard it's 20. And then, nope, I think it's 50 to 100. So when it was at 5 to 10 and then 20, we called in our backup surgeon, who happens to be an active duty military surgeon, and our anesthesiologist. And at the second notification, we activated our disaster plan. People knew. I'm really proud of our nurses and our emergency medicine physicians. They knew exactly what to do. Their role was to set up a triage center right outside of the trauma center, and it was really, really critical. So our nurse manager, again, knew what to do. Myself and Dr. Sakib, we had nothing to do with this. They did it on their own. There were 9 patients in our 11 beds. They moved them to the PACU area, literally bed to bed. There was no space in between them. We opened up our main, our ORs, our 3 ORs in trauma, and then we asked that the main OR open as many as they had staff for. The first wave of people was, I thought it was 20, about 20 came into our 11-bed area, and they arrived within 5 minutes. I later learned that our emergency department physician, she said, "Oh no, Debbie, it wasn't 20, it was 40." And she triaged those that she thought were less injured to an area that I'll show you in a little bit. We received many false notifications of additional shooters on the strip, and at one time we received a notification that there was an active shooter in the hospital. So this is again our trauma center. So people went through triage, whether they were self-transported or transported by EMS. If they were thought to be very injured, they came into this main area. And we have 11 beds. We double booked people as well. So these are our beds. This is our little blood bank as well. And the others who were less injured, there's this kind of a long hallway, and they went there as well. People then could go directly to the operating room and or the ICU, depending upon what was thought to be the issue. We created more emergency beds. So we have our 11 resus beds. We normally have 59 adult emergency departments. When Dr. Files, our trauma director, came in, he opened up the same-day surgery area in the PACU as additional ERs, and we had enough staff to basically open them up as ERs as well. Our incident command center was set up. This is our CEO, Mr. Van Heuling, and it was operational for several days. Surgeons arrived. There were 2 of us in-house at the time along with our residents, and so this is how people arrived. So after 1 hour, we had 5 faculty plus 4 of our fellows who are credentialed as faculty and residents. And at 2 hours, we were up to 8 and 4, so a total of 12 operating general trauma surgeons plus residents. You can see that we sent people home in the wee hours of the morning. Dignitaries, our capital's in the northern part of the state. I don't know if the governor was in the southern part, but he arrived around 2 in the morning, about 30 minutes after the mayor arrived and so forth. And they're actually kind of disruptive. So luckily our chief of staff, because they want information, they don't mean to be disruptive, but if you're just focused on taking care of patients, I had to assign people to them. Said, "You're in charge of the mayor, take care of her." And when she arrived is when we got notice. We got an overhead page that there was an active shooter in our hospital. So I put her in our locked trauma ICU, and I told her not to move along with her bodyguard. So how did we mobilize nurses and other staff? Our charge nurse called the clinical supervisor who was at home, and that clinical supervisor called in just 3 additional nurses. They all came in, and then within the hospital, all the nurses and PAs who were in other areas, this is part of our disaster plan, is they'll go down to bare bones for inpatients and other areas of the hospital, and those people will go to either the main emergency department or trauma. And many of them are not trauma trained, so she told them, "You all start an IV and hang a bag of IV fluid and treat pain." That was the initial response. There was phenomenal collaboration. And this is our trauma resus area on the night of the shooting. I was really happy to see people in PPE. How else did we mobilize resources? Our emergency physician, she kind of disappeared from this area. She was outside triaging, and that was critical. I think it was really life-saving for patients as well. And as I've kind of run through the rest of this, we opened up ORs and so forth. We called in attendings from multiple services. We don't have a lot of specialty residency programs, so we don't have residencies, let's say in neurosurgery and so forth, so all the attendings came in. This is the long hallway that we used initially to triage people. I didn't actually see people in these beds because I was busy inside. And then social services chaplain and our trauma interventional people were called in. So at our trauma center, in the first 24 hours, we did over 20 operations, and I would say that would be overnight. That it's probably not accurate for the next 24 hours. We did a lot of damage control. We had multiple specialties, and we had people who were hit in the head, and because it was from a high height, it actually caused also a lot of facial damage and airway damage as well. We did a lot of procedures, including Crikes out in trauma resuscitation. At one point, we had 8 operating rooms working. We canceled all elective cases. The next day, and I think this is really important, to be honest with you, in talking to the nurse manager, she didn't call in. She just called in the last 3 nurses that she had talked to that were on her cell phone. And then like her supervising nurses and so forth, they were like offended that they didn't get called in. One of our trauma surgeons was offended that he didn't get called in. But we need fresh people the next day, and I think that's always important to remember. We used, I should say, yes, we used, but they offered, internal medicine, family medicine hospitals, they all came up to us and said, can we take some of your patients who don't need active surgery and blood transfusions? And that was extremely gracious, and we accepted as well. The next morning we did a very comprehensive sign out with quite a few military people present, and they helped us keep on task for a good part of the night as well. And then of course we had lots of media and so forth surrounding the hospital, literally. These were our numbers. At UMC we had a total of 104 patients. We admitted 60. 12 went to the ICU, and we used about 70 units of blood. The 3 who died, I can honestly say, I declared 2 of the 3 dead. The 3rd one actually went to the main ED. They were dead on arrival, so we didn't lose anyone in the hospital, and I think the other hospitals can pretty much say the same. We have a joint military program. It's called the SMART program. This is Dr. Snook. He's in charge of that. This was invaluable. What I didn't realize is the military has their own way of notifying everybody who's active duty and making sure that they're actually okay. But that activated a lot of the surgeons because they said, oh, what's going on? Oh, there's a problem at, a shooting. Let's all go into UMC because that's where the credential. So what happened in the rest of our system? Some of you have heard, actually even at the American College of Surgeons, all 3 trauma centers spoke, and that was just a couple of weeks after the event. Our level 2, because of its proximity to the site, they got about double the patients that we got, and they did a phenomenal job. They used 125 crash carts in the first few hours. The level 3 that doesn't usually get any penetrating trauma at all, they got over 100 patients. There were 37 with serious injuries, and the trauma surgeon it was his first night. And actually he wasn't even planned to be on. Another trauma surgeon, his wife went into preterm labor, so they asked the new surgeon to start a day early. Desert Springs, which was 4 miles away, not a trauma center, they got 93 patients. So you can see, even if some of you are not at trauma centers, if there's really a mass casualty, any sort of large event in your area, you will all be really essential. What went well? Nursing leadership knew exactly what to do. Everyone responded. They voluntarily came in. Nobody complained. We had a lot of resources. We're a single hospital system, but we didn't nearly run out of anything, and we're the lead hospital in disaster management. And I think all of that went really, really well. We had a way of notifying physicians, but I think, frankly, we were very lucky that it happened during the news hour because a lot of people came in who were not called in. Some of the challenges, we couldn't register people quickly enough. Forget about EMR. I mean, it just isn't happening. Our phone system was overwhelmed, so we've now installed a second phone system for outgoing calls and mass casualties. So many people called in, nobody could make an outgoing call. tracking of patients was really challenging. I was actually the senior surgeon because the night surgeon, while he was experienced, I felt I just had more experience, and so he went off to the OR with the first patient who really needed to get to the OR. And it was challenging to keep track of patients, but in all the other areas, we assigned a surgeon, an anesthesiologist, emergency physician, and multiple nurses. And so I assigned a person in charge of each one of those areas, and they kept track of their patients as well. There was a lot of misinformation, as I told you about, and even the terminology we use internally, while it was confusing that night to others outside of our institution. Tertiary surveys just didn't happen until the next day. So in the system, before we started to have a lot of visits, we thought, what are some lessons learned? Why did all the roads get closed? We're not quite sure. Hopefully we'll learn that someday. Security protocols, while they were strong, they could be even stronger. Important for all hospitals to know how to set up a triage area outside of their hospital. Creating smaller teams worked in all of the trauma centers that were involved. There will be bottlenecks. In our case, it was registration. At every hospital, there was a bottleneck, and we need to be able to problem solve through those. Unnamed patients arriving. We did not run out of DOE names. Sunrise did, and so they ended up with, I'll just make up a name, they ended up with 2 John Does. Okay, so we've all expanded our naming convention. ATLS is very, very, very helpful, especially our level 3 made mention of that as well. After the fact, I'll talk about level loading in a minute. So we had the privilege of having the Assistant Secretary for Preparedness and Response come from the White House along with his team, and they then had a webinar that was very, very recent. They thought the EMS response was very good. There were EMS vehicles at the event that was planned, and they had a very robust response as well. But nonetheless, as we know in trauma, or in mass casualties, the majority of the walking wounded will in fact walk, and they did that night too. Or they got into buses. They found cars and trucks with keys in them, unbelievably, and they took them and they loaded people. We got 10 people in the back of a pickup truck. And there's a potential to redistribute patients as well. That's really important. And they felt it was important to be staffed indefinitely, and I think we didn't test that, but we probably have some challenges in that area as well. Damage control surgery was used a lot. They thought there was an opportunity to use it a little bit more than it was used. And they said not to forget that all surgeons should know how to stop basic bleeding, stabilize and transfer. Those are some basic principles. One thing that we do have is there is emergency legislation that's prepared to let people, healthcare professionals from other states get quickly credentialed in Nevada, but there really isn't a piece of legislation that would allow us to get credentialed at other hospitals within Nevada, and so that was a major suggestion, and I think we're taking that up. Be sure that everybody includes anesthesia in their disaster plan. We didn't run out of anesthesiologists, but I think we all realized how important they were, and support for patients and families. Most patients were unidentified unless they were talking. So this is re-triage. So a lot of the really minor injuries ended up in the trauma centers. So it was felt that they could have been re-triaged to non-trauma centers as well. Dr. Doucette is the author of the first edition of the DMAT book, and he traveled to Las Vegas along with Dr. Coimbra. And the second edition has just come out, and I think it's a really good course. Many of you have taken it. I'm not going to go through the details of it, but I think it is a really solid course and very much helped us. So thank you very much for helping us. Media relations will be overwhelming. This is our trauma director and our CEO, and I mean, literally, I don't know how people all the major news stations got there so quickly. The community outreach, I know none of you live in Las Vegas, but a lot of transient people, a lot of people who've moved there recently, and we really don't have a sense of community. But I think that really changed with the 1 October event. And honestly, for weeks, we had food brought into us. Recovery starts right away, we learn that, and boy, was that true. So these are all the crosses. This is the Welcome to Las Vegas sign. And this was up, I believe, for a month, and it will be in a museum in a few months. Everything's being cleaned up and so forth. Crisis intervention is extremely important. I think everyone suffered. Stop the bleeding training. We had kind of a slow start in Vegas. Boy, after October 1, we cannot teach enough of these courses. All the schools want to be taught. We had planned our statewide meeting on October 7th, so that's 6 days after the event. And we had standing room only for our Stop the Bleed courses. We've trained, now it's probably over 4,000. I need to update that. We teach 4 to 10 classes a week. Last week, we taught over 400 people, including nightclubs. So, it's a teachable moment for our elected representatives who visited our hospital, and it was stressful. A day and a half after you're finished, just triaging the people. A White House visit is not a minor event. Hundreds of notes. All the school children, they wrote notes to us, so they thanked us for killing the shooter. Of course, we didn't do that. So. Banners, dozen of banners from all over the U.S. So this is the part of the UMC team. This is part of the Sunrise team. Vegas Strong is a motto, and it's really been a unifying theme. These are the people who unfortunately didn't live. I'm going to take 2 minutes and go through this. Many of you may not realize this. And the same number of people die from firearms deaths in our country as do from motor vehicles and falls. The reason we don't know that is they don't come to our trauma centers. They go to the morgue. It's very lethal. I sent in a bunch of articles, too much, I think, to put on your syllabus, so I'm kind of paring those down and they'll be reposted. But we had planned this to be actually published on October 4, so it was actually released on October 2nd. I participated in several articles, including this consensus-based approach. If we think about our patients and our loved ones getting potentially killed, we need to find some unifying themes to address firearm injuries in our country. Mass casualties, while they're truly horrific, and I can attest to that, they're the minority of people who are killed. In our surveys, we think that violence is the root cause, and I've learned that a lot of good work has been done in the San Diego area. This is our website, and that's all going to be, my syllabus will be enhanced, so it'll be size appropriate. So we've come up with nine action steps. One is to support all of you in your trauma systems and Stop the Bleed. You're both doing that today. We want to understand from people who own firearms how we can work with them to develop an advocacy platform so we can get some sensible legislation passed. For the College of Surgeons, those of you who are members, you'll be getting yet another survey soon. We're going to survey over 50,000 people to find out what their opinions are. We know that we've already started to collaborate with other organizations, both surgical and non-surgical trauma and non-trauma, to see what we can do to work together. Injury prevention is huge, including safe storage. We're working actually on a brochure that you'll be able to give to your patients. We need to develop a research agenda, and we need federal funds. Federal funds have been prohibited for several decades now. This is the website of a nonprofit organization that both Dr. Stewart and I are on the steering committee for, that's trying to raise private funds for firearm injury prevention. Responsible gun ownership. It's a right in our country, so we need to really advocate for responsible gun ownership and nonviolent conflict resolution. So we've just signed a memorandum of understanding with the National Network for Hospital-Based Violence Intervention Programs. A lot of mental health contributes to this and other problems, so we really need to support our colleagues who specialize in that area. I know all of you are doing a lot of work in California on enhancing background checks and enforcing the laws that exist. So in summary, there's a lot to do, but in preparation for a disaster, planning, training, practicing is just really, really, really important. And train all of us and train our students, nursing students, medical students, and so forth, and stay involved. Thank you for your attention. I know I probably ran over a little bit over. I apologize, so I'll take questions during lunch.
Thanks, Deb.